Good afternoon and welcome to the Social Care Institute for Excellence's webinar on, as you can see, hopefully, the upcoming changes to the Mental Health Act and to the Mental Capacity Act. My name is Hugh Constant. I am a Practice Development Manager here at Social Care Institute for Excellence, or SCIE. SCIE has a long history supporting the implementation of the Mental Capacity Act, including that bit where the sort of tricky point where it rubs up against the Mental Health Act. And so we thought, as both laws are in the process of review of one sort or another, that it may be helpful to host a discussion on the changes that are afoot and what the interface between the Mental Health Act and the Mental Capacity Act might look like in future. We have with us a panel to which the word distinguished unquestionably applies, and I will ask them to introduce themselves in a second. First technological glitch is the slides aren't moving on, bear with me. Whilst the colleague steps in, thank you to do that. But before I ask the panel to introduce themselves, a word on the format. So we've asked you as the audience for questions in advance, and thank you to those that have submitted them. So after I've put some questions to the panel, we're going to put a selection of the ones you've submitted to the panel as well. In addition, you will see a chat box on your screen, which many of you have already used to introduce yourselves, which is super. Do please use that to ask any further questions and make comments. Now, we won't be able to answer those questions in the webinar. I don't think we're going to have time for that. But two things will happen after the webinar, okay? Firstly, a recording of this will go on the SCIE website by hopefully 4 o'clock if the IT winds are in our favour. And secondly, we're going to get in touch with all of you, if that's okay, with a brief follow-up to today's session, including information on support in this area. So hearing your questions and issues will be really helpful. Okay, but now, starting on my right with Mark, I'm going to ask the panel members to introduce themselves.
Hello everybody, my name is Mark Trewin. My normal job is running mental health services for Bradford Council, working in partnership with the NHS. However, at the moment I'm seconded to the Department of Health and Social Care and NHS England, advising them on mental health social work and working with the Mental Health Act review.
Brilliant. And Steve?
My name's Steve. I'm the Vice Chair of the Mental Health Act review. I have lived experience of being detained. A number of my family have been detained, and I have a diagnosis of bipolar disorder, and I've been supporting Sir Simon and the rest of the team to forward the review.
Baroness.
I'm Elora Finlay. I chair the National Mental Capacity Forum, and obviously as a crossbench peer in the House of Lords, I'm now involved in the progress of the Mental Capacity Act Amendment Bill, to which I've put down amendments and have been already quite involved in the discussions, and we've had day one of 3 days of Committee of the Whole House as this piece of legislation goes forward. And finally, Rachel.
Hello, I'm Rachel Griffiths. I'm now independent as a person with a huge interest in the Mental Capacity Act in particular, but also with the Mental Health Act. I was, until about a year ago, the lead for the Care Quality Commission on the Mental Capacity Act. I now work with Baroness Finlay on the National Mental Capacity Forum, and I'm also deeply involved with Health Education England in redoing all their e-learning on the Mental Capacity Act for doctors in particular, but all health workers. I also work a lot with providers and social workers, of which I am one.
Brilliant. Thank you, all of you. So next we're going to ask for an update on where the different pieces of work, the work on the Mental Health Act and the work on the Mental Capacity Act, are at. On the Mental Health Act, to begin with then, Mark and Steve, yeah, an update on where we are and the sort of implications as you see them for social care and health?
Yep, thank you very much. So the Mental Health Act review has been carrying on all year, published its interim report in May, and that was a summary of the call for evidence and all of the huge amounts of information that we received from professionals and service users and research. Since then, we've split into about 16 different topic groups. Each topic group is looking at a specialist part of the Mental Health Act. So to give you a personal example, I'm chairing the topic group on Section 117 and aftercare. So there's another 14 or 15 of those being chaired by other people. All of those will be reporting back to Simon Wesley their recommendations. Those recommendations will then form the body of the report, which ought to be presented to the government at the end of the year, probably December. What it means for social care, obviously, we haven't got enough time to go into the whole implications, but I'll give you some examples. It's going to have huge implications for social care, mostly, I hope, positive. The theme of the Mental Health Act review is about reframing it as a modern piece of legislation that can sit alongside the Mental Capacity Act and is linked very much to human rights legislation and the human rights way of dealing with people. We are looking particularly at the role of the AMP. We're also looking at the role of psychiatrists and other experts and professionals, but particularly I'm interested in the role of AMP, which I'm absolutely sure is going to expand. The respect for AMPs that's come out through the review is huge.
Yeah.
I also think that the Section 117 care planning bit is going to have a huge impact on local authorities as we try to simplify it and make it less of a nightmare for people to administer. Issues around CTOs will be interesting.
When I say CTOs, just
community treatment orders. Advocacy, but also there's a group looking at detention criteria. Do we stick with Section 2, Section 3, or should we do something that's more different and perhaps equalise the way that people are brought
we're going to
into
look at that
hospital?
question of detention
So
later,
all of those will have a real effect on AMPs and social work and local authorities.
Brilliant, thank you. Steve, anything you want to add to it from your perspective?
There's been a lot of talk around kind of, is this kind of a smoke screen? What is this? Having been involved in it for a year now, this is a process that is really taking this very, very seriously. We're looking at in depth these issues. I think one of the things that I really want to stress is the involvement of service users and carers right at the heart of this. We've got a separate service user carer group, and we've had service user and care representation of the topic groups that Mark has just mentioned. And also one of the driving factors behind this was the need to try to understand what is driving the overrepresentation of people from Black, Asian and minority ethnic communities, especially black people, and we have a dedicated group looking at that. So again, I really think that we've got quite a challenge, but I think that we have taken it head on, and I look forward to seeing what we create.
Fab, thank you, and we will kind of pick up on some of those issues as we go through the questions. If I can take us now to the Mental Capacity Act and where we are with the Mental Capacity Amendment Bill. I ask Baroness, you introduced it into the House of Lords this week?
No, I didn't introduce it. No, it's a government bill.
Yeah.
I've spoken.
Sorry.
I've spoken to the bill and have been involved in tabling amendments to the bill. I think it's really important to remember that the Law Commission ran their consultation because there's been a crisis with doles. So this has been because we know that there are probably about 120,000 people now in places of care who are deprived of their liberty, who've never had any assessment done at all. So and the numbers are going up. So there's a crisis and it's got to be dealt with. The Law Commissioner report was very thorough, well consulted on. And then the government felt, I think, that we really need to do something fairly urgently and actually slim down to the essence of that report. And Tim Spencer-Lane, who was the lead on the Law Commission report, has been part of the bill team on this new bill. So people who say the one is disconnected from the other, no, that's completely wrong because there's continuity. And this is about getting liberty protection safeguards. And I think that's important to remember The previous situation was about deprivation of liberty, taking away liberty. This is trying to turn that on its head and say, how do we protect liberty, but also maintain security? So how do we really use Article 5 properly to protect people from harm that either that they may do to themselves mostly, but might actually harm others in the process too, given whatever has happened to them and whatever means that they need additional security, and how do we keep them secure? So it's the balance between empowering and protecting, and the focus has to be on making sure that people are empowered, and how do we improve the day-to-day experience of the cared for person? Because at the moment you get all these assessments done, people come in, they kind of catapult in, they do in detailed assessments, they write a report on it, and they go away again. But 2 months down the line, if things have slipped backwards or things aren't really being well implemented and aren't embedded in their care, then actually one may not have achieved very much. And I've been horrified to hear that there are even people out there at the moment in care homes who don't seem to have a proper care plan. Well, that's got to change, and it's got to change fast. And if we can get that process of saying, what does this person need, and why do they need it, and then what's proportionate to meet their needs, and how does it respect their wishes and feelings and the type of person they are in their environment. If we can get that embedded right the way through, hopefully we can improve the care that people have and provide care which is more compatible with the aims of the Care Act too.
And I'm going to ask Rachel in a second to sort of comment on what the implications of the changes to the MCA might be. Is this a fair question? Do we have any idea of when the law might receive royal assent?
Yeah, I mean what matters is when it's implemented.
Yes, and then the implementation.
Okay, yeah. So it's going. So basically, we've had day one of 3 days in committee. We will then have report stage, which will probably be a day in the Lords, and then third reading, which will be another day. Then it will go to the Commons, and I think it will have been amended. I think we've had some incredibly constructive discussions already, and the Minister is definitely in listening mode, and that's absolutely clear. And then when it's gone through the Commons, we still will have a year probably through the phase where the Code of Practice is fully written and consulted on and so on. So I would guess that we're talking 2020 for an implementation date.
Okay, lovely. Thank you for that. Rachel, if I can then ask you, as Baroness Finney has explained, you know, that the amendments to the MCA will replace doles with the liberty protection safeguards. What will the implications be, do you think, for the people deprived of their liberty, for care home managers, for local authorities? I'm going to put this question to Rachel first, but, you know, would invite other panel members to chip in, obviously.
Okay, Hugh, you'll probably have to hit me on the head to stop me.
I'll get something less dramatic with
it. These are the $64,000 questions, I guess, particularly the first one. Like everybody else, I am so pleased that we are starting practical work to do something about all the people who've not been getting the protection that doles did give when it was used properly and when deprivation of liberty was recognised. I never was quite as against doles as many others were, and I'm amused therefore to hear people now saying, oh dear, maybe we were better off in the olden days. It's been quick to get to that point. It is important that deprivation of liberty, whatever you conceptualise it as, I like to think of it as something around that person's human rights to live as they choose as much as possible. And this obviously applies in mental health settings, acute and less acute, but particularly to all the people who are in social care settings where they are not allowed out and not allowed to do as they wish. And the question has to be looked at by somebody, is this the right way, the least restrictive way to care for these people. So I'm very pleased that we have started, I hope, some very constructive, practical discussions on how to achieve that. The implications for care home managers. Currently, I think many of you listening will have heard tremendous concern, which I am always pleased when people are talking about mental capacity. So I don't mind this, and I don't mind if people agree with how I now see it or not either, really, because I think we're all feeling our way towards what the future should be for the people in class one, the people who are or who might be deprived of their liberty. Care home managers are going to have a lot more expected of them in the new system, more so than supported living providers, oddly, and people in other community settings. Now, this can be turned to great advantage, but that's not going to happen if, as I do take issue slightly with the Minister's response on the first day of discussion, where the line appeared to be very clearly that we are asking them to do things that they are already doing. I think you have to start from accepting that you are asking them to carry out a lot of tasks that have been carried out by the local authorities. This is where the third group of people on the slide come in as well, and by the assessors sent out under doles. So if we don't accept that, I think we risk two things. One is that they are going to be very alarmed, very worried, possibly even in some smaller care settings, just jacking the whole thing in and thinking there must be easier ways to get an honest living. And also that they will try their best but not do it as well as we need it to be done. So I think we've just got to recognise that there are issues here. When we turn to the local authorities, yes, they've been hugely under the cosh. They are having taken away from them and given to care home managers a lot of the tasks, if you want to think of it like that, of arranging assessments, maybe even doing them, making decisions about advocacy and all kinds of things. But the local authority will still be expected to sign off this authorisation. And I think there's a real question about the risks of that turning into just a kind of rubber stamping desktop type thing. A lot depends on the detail here.
Anyone else? Mark? Mark and then Baroness?
No, I was actually just watching the chat that's going on down the side. And I don't know where anyone's got the idea that we've bought into the care home, the idea that care home managers are always to be trusted and sitting around twiddling their thumbs. That's complete rubbish. They're under huge pressure. I've been involved in prosecuting care homes. No bad care homes. I've got relatives in the care home, and in this country and in other places. I have had. She's just died, the one who was in France. But I think the problem has been that we've just got escalating numbers of people that the system can't cope with, that haven't been looked at properly, and we're not going to magic out of thin air huge numbers of fully trained staff suddenly to start dealing with it. And you have to say, has it been proportionate for everybody? I don't think that we've consulted families nearly enough up until now. The information that they have is often absolutely gold dust. And they know this person. Most families are really caring, loving families that worry about what's going on. If you take one family member in a room with 5 professionals, you can't say that's a best interest consultation. There's such an imbalance in power. And I think all of us, and I speak now as a doctor, as professionals, need to realise that actually each person in front of us is individual and unique. And we really do have to listen to the people who know them, and we have to do all that we can to strengthen that cared for person's ability to take decisions. however we do it, using pictures, taking them for a walk, see what happens. And just one story which I heard about, which I think illustrates
and then
it.
I'll go to Mark.
Yeah, was a lady who got very agitated in a care home when it was snowing. And the care home couldn't understand why she was so agitated. Then her son came and said she used to work for the Met Office and her job was to measure the snow. So they actually wrapped her up, let her go outside with a measuring stick. She measured the depth of snow. She made a fake phone call to the Met Office. They didn't actually put her through to the Met Office, but she had a conversation. She was completely compass mentis over measuring the snow and so on, and she was calm. You have to know about the individual person.
Yeah, absolutely. Mark?
Yeah, I wanted to make a general point really about all of the concerns about both the Mental Health and the Mental Capacity Act changes. And this is really something that I think we need to engage the government in this conversation. About a lot of the time, we appear to be trying to legislate or to produce guidance to compensate for the failings of the organisational systems in which we work. Now, you know, as somebody who has both a national and local view of social care, I could see brilliant social care and health and nursing happening all over the place and fantastic, and I can also see it failing a lot as well. And the reasons for that are complicated. And it is impossible, I think, to use the law to compensate for those things. One of the things that Baroness Finlay said in her introduction was about numbers of people in care homes who don't have a care plan. I mean, that is a failure of the basic work that we all ought to be doing. In my role with the Mental Health Act, looking at recommendations for care planning, we are looking at, should we make care planning statutory? You know, how practical is that? Because how can we guarantee that every single person has a proper care plan where some professional has actually looked and talked to them and their family and come up with some coherent system as to how we can improve their life? And this is all about resources. So the law will not give us more resources. We need a balance of good law and good planning for public sector resources.
And I suppose that's a law that balances robustness with manageability, I suppose, and that's the challenge. Rachel, sorry, if you wanted to come in on this and then we'll move on to the next question.
Yes, I think a lot of what we've been saying and some of the comments I've been reading that are coming up from people listening remind me all the time that the Mental Capacity Act is not yet where it ought to be. And simply by having these discussions and by Parliament and the House of Lords discussing these things, it is a help to remember that if we're getting care right within the basics of the wider Act, then the questions around deprivation of liberty are going to be answered so much more easily and not appear like something parachuted in. Good care is not something that gets parachuted in by a BIA or by anybody else. It's recognising the position that we should all be in. And they say that any law takes 20 years to get into practice from being formulated. I don't know who says that. They say it. In which case, the poor old MCA is on the homeward stretch.
It's halfway there.
The more we can do, the better, I think, to encourage working within the basics.
Okay, I'm going to starting with Steve, but again, if anyone else, feel free to chip in. I'm going to ask about what has always struck me as one of the trickier areas of the MCA, and about how it interfaces, so it's a terrible word, with the Mental Health Act. So Steve, do you want to talk about the current situation, then we'll go on to a discussion about what the future might look like?
I will do my best. I'm not a legal expert, so there's kind of my understanding of through the process, but also as a service user, and I'm aware that as somebody who has been detained, that my views might not be the same as other service users and carers. I think it's important to say that we were asked by the government as part of the review to look at this interface. So we've got our process here, and there's the process of the bill going through the different houses. Any recommendations that we make will not impact upon that process, so we're not interfering with that there. There's a few points that I kind of want to mention before I kind of get into my response as such, and I really appreciate Baroness Finlay's point around trying to better understand those individuals. And I think that when we think about the terms of reference, we've got it in there that we want people with mental health problems to be treated with dignity and that their liberty and autonomy is respected as far as possible. And on the face of that, that's quite simple. I think there are some slight differences between some of those words, and I'll kind of explain what I mean around that. Autonomy is incredibly important, and I think throughout the review we have been trying to fully understand what that means. And I think that Mark spoke about these topic groups, and they're looking at individual elements, but actually the issue of autonomy and dignity runs throughout, and it's safe to say that there are some real challenges, especially with respect to the fact that there are times when people do need to be detained for their mental health. And one of the things we did earlier in the year was we did a survey of both service users and carers, and we did a number of focus groups, and that came back with a real split down the middle. Certain people saying that they absolutely feel they should not have been detained, other people saying it was absolutely right, and and people voiced that it was life-saving. And that's the position that I kind of come to. If I hadn't been detained, I wouldn't have got my diagnosis of bipolar disorder, and it's notoriously difficult to get a diagnosis. It could be 10, 15 years, and that could have wreaked even more havoc on my life there. But what was consistent was people saying it was the experience that they had that made it bad. So again, it's the things you've just spoken about. It isn't necessarily about the law, although the law is important. And I think kind of just getting into that question around what are the issues, I don't believe that the Mental Capacity Act and the Mental Health Act are equivalent mechanisms. And I think, it's because they've come from different positions. And everybody listening to this probably knows far more about this than me. But when we're looking at the Mental Health Act, it is really focused on that element of treatment. I think that some of the concerns that I have around DOLS and LPS is that on the face of it, it looks better. And I think it's absolutely right that we try to find the way to maximise a person's autonomy and respect their capacity. The bit that I have major concerns around is the treatment and those treatment safeguards. And one of the things that we've been really, really mindful of through the review is that if we're going to change a safeguard, that we need to replace it, and ideally we need to strengthen those safeguards. And I think coming back to the idea of experience, when you are in a position where your mental health has deteriorated to the point when you have to be in hospital, that is one of the most difficult experiences you will ever have, not just for you, but also for the people in your life. Being able to challenge that treatment needs to be as simple and as easy as possible, and the first protocol is the SOAD.
You spell that out?
Sorry, second opinion appointed doctor. So that's somebody who can look at what your responsible clinician has said you need and say yes or no. And then do you have access to a tribunal where again you get to challenge your treatment. Now it's safe to say that the SOAD is easier, and actually it's less intensive. Even the idea of going to a tribunal is quite difficult. When we think about the LPS, the fact that actually you probably have to go to a court of protection. Even the word court just kind of sends shivers down my spine, just to have a conversation with somebody about my treatment. So I don't think that they are the same, and I keep coming back to this word around experience. And for me, it's almost what is leading us. Are we being driven by the process, or are we being driven by experience and outcome? And actually, for me, knowing the fact that if we're going to be detaining people because of their mental illness, that actually they are going to be given treatment. That treatment might be appropriate, and they might think, yep, that's right for me. It may still be appropriate, but actually there are a number of options, and they prefer option B over option A, and actually that they should have that choice there. For me, it's trying to understand the balance there, because actually if you're in hospital for an extended period of time, not being able to have a choice over what's going on in your life, is that going to be more traumatic than not having your wishes taken into account? I do think, and I think we're trying incredibly hard through this process to understand how through the Mental Health Act we can increase people's autonomy. We're looking very seriously about how we use advanced decisions. And I actually came across mine yesterday, and I saw my psychiatrist, and we had a quick look at it. So, based on the fact that I have a long-term mental illness, and I've been in hospital, we've taken that very, very seriously, and that's where we can kind of put those wishes. The idea around choose your nominated person, again, the hierarchy would say it's my dad. I don't want him anywhere near there. He's part of the reason that I ended up with this illness. So I know that what I've just said might not sit well with some people, but I think that there's a real tension here between process and experience.
Okay,
I think you absolutely hit the nail on the head, because the culture behind the way that care is given is what determines your experience, and what your experience determines your outcomes. And there's absolutely no point having any process if you don't have improved outcomes. I also think you've hit the nail on the head, because people are looking to legislation to solve a problem. I do have a worry that if we put too much in primary legislation, it becomes difficult to change it later. And I would quite like to see us take stuff out of this and have it in regulation, so that you can change that more quickly and be flexible, because we don't know what the future holds. Nobody predicted the Bournemouth Gap. Nobody predicted Cheshire West. Those are extreme cases which have landed us where we are now. So we don't know what's going to happen in the future, but we need to be able to move a system to adapt if necessary.
And I'm sorry that you take the view that we don't know what's going to happen in the future, because that was very much the basis of my next question, I suppose. And I'll bring Rachel in on this as well. Given what we do know, and some of the issues that Steve has talked about the interface at the moment, what one desirable outcome, presumably, from these twin processes would be an easier interface. What do we think that the introduction of LPS and the review of the Mental Health Act might mean to the interface, and that tricky question, particularly of the criteria under which people are detained?
I think that we've got to remember we're dealing with very, very different populations a lot of the time. There are people who are in mental health services because they have mental illness, but they are otherwise fit and well. There are a lot of people who have multiple comorbidities, who have got mental health problems and lots of physical problems as well. And the two interplay, and the one makes the other worse. And then we have people who've had just dreadful things happen to them. They've had catastrophic head injury. And there are groups of people, someone with a frontal lobe paradox, where they've lost the front part of their brain by and large, is completely different to somebody who's got schizophrenia or bipolar disorder. And it's really dangerous to think that you can come up with one system that's a catch-all for everybody. So I hope the words don't come back to bite me, that we will be looking with LPS eventually at something which is much, much more flexible and able to meet the needs of the individual person in the context from which they've come and whatever disease and process they've got going on, and that will ensure that they are looked at and reviewed, and if they've improved, that things are made easier and relaxed, and if they've got worse, that there's a timely response to it, but that we don't have the kind of stigmatizing view that you can put them in one framework and then it's sorted, because that separates them from the rest of the society, and they're not. And then people who have really severe mental health problems where they need intervention and treatment, I think that's something else. I do worry if people hide behind the Mental Capacity Act for providing treatment to which somebody isn't consenting.
Mark, Rachel, any?
Yes, this is such a kind of huge and central requirement for us to get our crystal ball out and decide what it is going to look like. But when I think about the interface, I do come back to remembering that nothing in the Mental Capacity Act, because it said so explicitly, changed anything in the current Mental Health Act, and that a lot of the confusion between the two acts, I did feel, honestly, yes, I know there were some really difficult cases which were extremely interesting and had to go to court because they were so subtle and raised new questions. Most of the time, I felt that it was actually fairly easy to decide which framework was the best, most appropriate one to protect the rights of this person at this time. I think we mustn't forget these are the same. These laws, both of them, are about protecting the rights of people who are being treated, as Steve, you've really brought it vividly into our minds, what it is like to be a detained patient. It is vital that you have ways to exercise your rights and to have your basic rights protected, even when you're so unwell that you cannot do that for yourself. And as long as we remember that this is what the interface, wherever it rubs down eventually, is going to achieve that, I think is absolutely essential. Within that, this may be something that we're going to talk about later, but I increasingly agree with the views of the interim report that the Mental Health Act does seem in some ways very old-fashioned and patriarchal. As a former AMHP, I would have blessed getting rid of nearest relative, which actually had me end up in the High Court once because I got it wrong. But anyway, and I concur with Steve that going to court is so scary. Utterly terrifying.
Can I just kick in one thing that I forgot to mention? So we've got the idea around rights and safeguards, but then we've also got entitlements.
Yes.
And I think one of the concerns for me is that you could have two people who have got very, very similar needs. One presents with capacity, and one presents without capacity. And if we kind of go down the idea of only using the Mental Health Act for people who have capacity and are not consenting, that actually the other person goes on to LPS and doesn't get those entitlements. And the biggest one is Section 117 aftercare. And that for me is really arbitrary. And I'm not sure that, well, I don't agree with that. And I know you've got to draw the line somewhere, but when you're basing it based on how someone presents, and the other thing that does concern me about LPS is the best interest test. One of the key things we've got is we've already got a system that doesn't work for people of different ethnicities. The idea of best interest and you know, we've just discussed that actually are family involved or the people closest to that person involved. Could that end up really disadvantaging, you know, African Caribbean people in particular?
Yes, I won't repeat what my learned friends have all said about this, just try to pick up some other points. First is we are looking at nearest relative, you'll be pleased to hear, and we are looking at equality of access for Section 117. But in terms of the interface, we've talked a lot about the legal interface, so I'll talk about different bits of interface. There are certain professionals, particularly AMPs, also doctors, often nurses, who are often they're often stuck with the front end of the interface. It's late at night, they're in a difficult situation, they've got a very vulnerable, unhappy, disturbed person in front of them. They want to know, which legislation should I use? Which is least restrictive, most respectful, most likely to keep dignity, and most likely to respect human rights, but also solve the problem that I've got in front of me. And I think our job as legislators, and the government's job, is to make that easier for them. So that's one of the things. The other thing that we often don't talk about, which is really important, is the interface between health and social care. There's an awful lot of talking about integration and what a great thing it is, but in actual fact, the interface between health and social care is often very unhelpful to professionals on the front line. Yeah. So one of the things we're also looking at in our recommendations is how to make that better. Because I think we've got to, the lives of frontline professionals and the service users that they look after is made much more difficult by the complexity that we put into systems. You know? So get the law right, get the system around the law right, get the resources around the systems around the law right, and people will probably make better decisions.
Yeah.
The law can only be a scaffolding at the end of the day. And I do think somebody's put up on the side, it's Karen Davis from Wales, and welcome her flagging up. It is that decision at that time. That's what we're looking at capacity for. Not a blanket, you have it or you don't have it. Really important.
Yeah. Rachel, very briefly.
I will just add really quickly that I have gained enormously from having access to the new Mental Health Act Code of Practice. I say new, the 2015 one, because Chapter 13, where it discusses the relationship between the Mental Health Act and the Mental Capacity Act, I think does present to us certainly some pointers towards best possible practice in the current system that I think we ought to take forward in whatever we end up with.
And that's not widely enough disseminated.
Yeah, no, absolutely. Steve, can I ask you to lead on this one? So, I mean, we've talked about the MCA feeling perhaps a less kind of, I think Rachel used words, patriarchal about the Mental Health Act. The MCA has brought a shift, I suppose, in health and social care that looks about encouraging autonomy. Linked to that then, and in discussions earlier this was described as a contentious question, should it still be possible to detain people using the Mental Health Act even when those people have capacity to make their own treatment decisions?
I mean, I feel like I've kind of partly answered this. I think that based on where the MCA is at and the fact that I don't think it has the same robust safeguards, I would, speaking very personally, I would prefer to be detained under the Mental Health Act. And if I'm being really blunt, at the point at which you are detained, you don't care what bit of law it is. What I care about is how. How are you treating me? And how are you treating me? Can you get me out as quickly as possible so that I can return to my life? And will I have a say in my treatment? I absolutely want you to respect my capacity. But I have I think that I have no faith in the fact that even if you're using Mental Capacity Act and you're saying this person has capacity, at that point, I have no confidence in the fact that that will be respected once you're then into hospital, because it's about the practice. So again, just because of what's going on at that point in the assessment, actually I was at a session on Monday which is all about the experience of the assessment process, and we heard some stories of some truly horrific practice, but also some really good practice where people were respected, where they had, even in that situation, they had a say in, well, which room should we have the assessment in, and how is it going to be done, and even though these are really small things, they were respecting that person. Respect is not something that you can legislate for. And I always come back to this idea of how do you make sure that people who are in the caring profession care? Yeah. And that has nothing to do with following process. That's to do with care. And I think that Mark's alluded to the resourcing issues. I think that what sits around this is the fact that we have a workforce who are under huge strain. We're expected to do more and more work, and we're then expecting them to deliver care, not a process, care. So that's probably answered that, I hope.
No, that's brilliant. And Mark, I just wondered if you wanted to add to that.
Yes, I mean, I agree with Steve. I think that there are times when the state needs to intervene in people's lives, and I think that the issue about that is the quality of the intervention. And one of the things that worries me is that when we intervene, we often then intervene badly. We then send people 250 miles away for a bed. We then keep them in hospital way too long. So for me, it's not the intervention that's so much the problem. It's what happens immediately afterwards. Yeah. I would like to see that when we intervene in people's lives, when we detain somebody for very short periods, with a huge amount of legal control and a huge amount of respect for human rights, and that we are then taking them through a therapeutic and supportive process that helps them to reinstate them back in the community in exactly the right way possible for them. Yeah. And if we can do that, then that will be a much better system than we have now. And that's what we should be worrying about, less than, more than worrying about whether or not we should or should not detain. I think that's a lesser question.
Rachel.
I do think this question has underpinning it a kind of lurking reference to the possibility of fusion law,
Yes.
combining the two acts. And I'm aware, without knowing any of the details, so nobody asked me to stick up for myself here, but I am aware that the Northern Irish fusion law has led to certain unexpected problems. I don't think that's any reason for us not to see that as our long-term aim. I think people's capacity, as Steve has been saying, it's however you're going to think about capacity, it's encouraging the importance of the person's wishes and feelings in everything that happens in their own lives, and stepping back a bit from the assumption that professionals know best, even when sometimes their expertise is needed. So I would like to see us still exploring towards fusion.
Can I just quick? So I think this is one of the issues that there's great confusion about what the review is doing and are we looking at it at all. I think that we had a very short timescale, and I don't think that allowed us to look at this in the depth that was necessary. I think when we talk about fusion law, there isn't one meaning of it, and I think that I would absolutely. I spoke to one of the lawyers that's supporting the review, Alex King, yesterday, just to try and get my head straight on some of this stuff, and he said, "You do realise, Steve, you're probably advocating for fusion law." And I said, yes, but just not now, because I think actually, if we know anything, is that these processes should not be rushed.
I think you're right. I do agree.
And I think that is a shame. But I do think that, trying to find the best solution that encompasses all of these things is really important. I just don't think we're there yet. But the review will make a statement on what that could look like in the future.
That. No, you're absolutely right there.
The last question from me, and then we'll go on to some of the questions that the audience submitted. There is a suggestion from some people that the LPS seems to be shifting towards a situation where a deprivation of liberty might be, for the reason that of someone lacking capacity, preventing the person lacking capacity harming others. Rachel, what do you see as the implications of that shift? Did you agree that shift's lurking in there? Or?
I have learned and changed my view quite a lot on this over the years since the MCA came in. I started out very gung-ho about this. It is only about harm to the person. But what I saw in practice was that increasingly people were getting themselves tied up in terrible knots that were slightly, well, more than slightly, dishonest knots to explain why, when really the risk was harm to others, it was harm to the person. As in, oh, well, it would be very harmful to Jimmy if he starts whacking other people, because if they whack him back, it'll hurt him. Or we will restrict his freedom because he's whacking others, therefore it's harm to him. Anything that brings truthfulness into practice, I think, is worth encouraging. Having said that, I do think that we have to be careful that we're not just stoking the risk aversion of many professional groups, you know who you are, in this. So again, I'm very good at arguing with myself, but I think I will do anything sooner than have that dishonesty continue.
I'm going to move us on then to the audience questions. We have about 10 minutes left, and we have 5 audience questions. You're all capable, therefore, of working out that we need to be quite swift with these. Mark, what can the Mental Health Act Review do in an effort to reverse the increasing number of detentions? I'm sorry, I know I don't have records of who sent in these questions, but thank you for the many people that did. We're only able to answer a few.
Thank you. That is a great question. Cuts right to the heart of it. I think there's a lot we can do, but as I've said before, at the risk of repeating myself, law is only one part of it. One of the issues that we have done is we've looked at a big evidence-based search on what actual alternatives to hospital work and don't work. There's a lot of experiments around the country, crisis houses, crisis centres, alternatives to A&E, street triage, lots of social care-based housing and other implementations that are supposed to be trying to support people not going into hospital. I think one of the things that we found is that there's no actual evidence that any of these work or don't work. So a lot of the time it's about gut feeling from professionals and service users as to what they feel is best for them. I think that it's mostly wrapped up in the community mental health services. I think we have to completely redesign community mental health services to back up this new legislation, because that is the thing that will stop people from going into hospital. One of the things that's become apparent is that an awful lot of people detained have not necessarily been seen that recently, and you often question as to whether or not the detention was necessary if those people had been receiving different levels of support. There's also issues around the boundaries between primary and secondary care and the interface between health, social care, and particularly housing, and particularly supporting housing, which I think is a real remit and a way of early intervention when people are starting to become unwell but have not yet reached the criteria for detention. So the Mental Health Act review is going to make numerous recommendations about all of those things, but I would say that it's probably not going to put very many of them into law, because that's not necessarily the right way of doing it. So we will be having an expectation that the government, through the Green Paper for Social Care, through the long-term plan for the NHS, will be doing sensible things with mental health and funding those sensible things properly. And that will then, we will then create a legislative framework that can meet and work with those sensible things, and hopefully the two will happen together.
Brilliant. I mean, a question that I suppose reflects the emphasis that we've been talking about, that it's not just about law, it's about practice. Highlighting an issue of poor practice here, a concern that people are sometimes coerced into consenting to voluntary admissions with the threat of a section if they don't. Is that an issue that's come up in the consultations, and is it addressed at all?
I think it has come up, and again we've talked to a huge number of service users, and they told us a huge number of things, which, as Steve has said, has frightened us with how bad services are and filled us with joy about how great services are, depending on where it is. So I think one of the things that people have said is the idea of the informal patient has been lost because of bed crisis and crisis in services, and the idea that people have gone into hospital informally, and then when they've decided to take their right to leave, have then been detained. That's one of the things that's been raised, and also about the way that people work in the community sometimes. I think it is possible to safeguard against that, but I think the biggest safeguard against it is having a service that can be flexible around people's needs. Because for most AMPs, all AMPs and doctors, I'll put my neck out on this, they do not want to be detaining people, and they want to look for the least restrictive alternatives. Yeah. And the problems for AMPs and doctors is they often do not have least restrictive alternatives to be able to choose. Yeah. So I think we need to be starting to give them proper least restrictive alternatives, both in their work as AMPs and doctors, but also in their work as consultants and nurses and social workers and OTs within their community teams as well, so they can start making better decisions for people.
Just let's not forget, most of the crises arise out of hours. So that's an additional problem. The services that only work in hours are not beginning to meet the need. So there is a huge service change that we need, and we don't have enough beds just to accommodate the people who need to be put somewhere safely, actually for 1 or 2 nights even, let alone when we start talking about treatment and so on. And the other thing is that we need to put them not only somewhere safely, but that is acceptable to them. The worst thing is to put somebody back on a ward where they were traumatised previously. And we know that's currently happening because there's nowhere else to put them. In the whole system, I'm afraid, I think we've gone so much into pushing out to the community that we've forgotten that sometimes people really do need to have an appropriate safe place for immediate care.
Yes. Bernard, I'm going to start with you on this one.
Sorry.
Do you think there's an issue that different professional groups have a different understanding of the MCA and therefore apply it in different ways?
Oh.
The actual question named some certain groups that they thought were rubbish, but I thought that was a bit contentious, so I neutralised it.
Right. Okay.
I mean, do you think so? Can we ever tackle that?
Yeah, I think we can, but it has to be down to the regulatory bodies that do it. If if every doctor, as part of their revalidation through the GMC, has to be able to recite inside out and back to front the 5 principles of the Mental Capacity Act, and every nurse could and every social worker could, and really understand what that means, I think we'd have gone a long way. Unfortunately, assessment drives learning. I've interviewed the medical schools. It isn't in the nursing curricula in all nursing schools, I'm afraid. Medical schools say that it's in all their curricula. I remain to be convinced how effective that teaching is. And one of the other problems, of course, is that you have to reach the hard to reach group within anyone. But thinking a professional label is particularly linked to it, I think is, no, it isn't. You've got really good practice and you've got really bad practice. But I would like to see training simplified down to the 5 principles of the Mental Capacity Act. I think if everybody understood those, we'd have gone a long way.
Thank you. What last time I pressed the button? Rachel, very quickly. Do you think there were knock-on implications for safeguarding in the changes that have taken place?
I'd say 2 things really fast. Safeguarding has suffered badly in the last decade from being associated with risk-averse practice, and it's tempting, and I'm not knocking safeguarding professionals, but I do think that the empowering ethos within the Mental Capacity Act should be part of all training for safeguarding professionals. The real knock-on implication, however, for the changes, and here I'm going to name-check you, Elora, is I worry about the name, I worry about having safeguards, I worried about deprivation of liberty safeguards, which led, I am certain, to the practice whereby MCA leads were subsumed into safeguarding teams under the safeguarding umbrella because it was all seen as the same thing. And Elora, you did suggest in the committee stage possibly changing the name because liberty protection safeguards is still going to risk the same thing happening. And you suggested liberty protection arrangements. And I thought that's absolutely brilliant, except then we're going to have the mix up with the Office of the Public Guardian and LPAs as lasting powers of attorney. But liberty protection system or just liberty protection, I mean, please, somebody suggest a better name that doesn't involve safeguards.
I know, completely agree with you. LPA, real problem. Why not call them LPAS? So liberty protection arrangements, and the S on the end is in capital letters.
Oh yes, right.
Okay, but I think we have to absolutely. That word safeguarding is really dangerous.
Okay. I want one word from each of you, starting with you, Mona. The only words you can choose are yes, no, or maybe. Will people's rights be strengthened as a result of the changes being proposed?
I hope so. I don't have a crystal ball.
Oops. Steve?
You stole my answer. I said we certainly hope so.
I'm going to be positive and say yes, as long as we all remain rigorous in our challenges to the proposals.
Yes, if they're implemented properly.
Brilliant. Okay, folks. Just before the poll, we're going to ask you whether this has been a useful process. I just want to highlight, you know, there are all sorts of things out there supporting the implementation of the Mental Capacity Act and the implementation of the Mental Health Act. So, some resources: the Mental Capacity Act Directory, the Office of the Public Guardian, Baroness Friendly's National Mental Capacity Forum that she leads, 39 Essex Chambers, wonderful legal information there, and the Law Society. The report that Steve and Mark have been working on is available on the gov.uk website, as are their terms of reference, and again, lots of useful information from charitable sector groups. SCIE has a host of stuff on the Mental Capacity Act as well. We are now going to put a poll up on screen just to check whether you found this session useful. I've personally found it incredibly interesting. I could go on listening to these for all afternoon, and I'm sure you could, but not many people in the health and social care sector have much slack in their diary on a Friday afternoon, unfortunately. So I am going to draw it to a close. So the poll is now open, so let us know what you think. Whilst you do that, just to repeat, this will be on the website at 4 o'clock. And we will be contacting each of you with a kind of a transcript of the chat and a kind of overview of the session and some kind of useful resources that we might like to point you to. I would like to thank Baroness Finlay, Steve Gilbert, Rachel Griffiths and Mark Trewin, my colleague Steve and Susanna have been doing wonderful work in the background, and thanks to all of you. I hope your Friday afternoon is peaceful and that you have lovely weekends.